All right, ladies and gentlemen, we'll kick off with a panel. Invite our speakers to come up and grab a seat, grab a microphone. And Tony Dowling, Tony Dowling. Thanks for coming on stage. You're going to come on stage and throw some more. Some mind-blowing stuff there. Some incredible innovations, some amazing things that are coming, and some things that are amazing here now and today. So a panel just to address a few questions, and then we'll also take questions from the audience. So I guess my first two questions, I feel a bit nervous now because my first question was like, "Oh, radiologists are about to be replaced by ChatGPT," but it sounds like physicians are about to be replaced by ChatGPT. So who should be nervous? Son?
Definitely the physicians.
Definitely physicians. So, but I think one time you said to me that it won't be radiologists replaced by AI, it'll be radiologists who use AI replacing radiologists who don't use AI. Do you still stand by that?
I think so, and I think that's going to apply for physicians as well,
Um, so,
and researchers.
and researchers, yeah. Well, researchers are using AI at an increasing rate, right? Outputs are surging.
Yeah. So, just for example, grant writing. Um, I'm sure everyone uses Claude or ChatGPT now. But if you're not doing it agentically, you're already a step behind everyone else who's doing it agentically.
So,
Um,
so using an agentic AI, write a prompt, say, write me an NHMRC grant.
yeah, so just for example, I might um, upload, here are the grant documents, here are all the guidelines. This is some ideas I have, and I've got a Claude skill set up to take a conversation about an idea and convert that into a grant application. Um, in the sense that, so I'd have a conversation about, look, I want to study MRI biomarkers for prostate cancer recurrence, and that might be my starting point. And then, like an hour later in the conversation, I've honed into a one or two, um, specific questions, and then I can pass that conversation into Claude using the manuscript skill. Oh, sorry, that's a different skill. The grant writer skill, and to start to draft the grant. But I can tell it to use the grant documents, the guidelines, the specifications to write to that grant. And if you take it a step further, you can look at. I haven't tried this, but it's not difficult to do with agentic AI now. You can map out the entire landscape of successfully funded grants. Those databases are publicly accessible by the agentic AIs. You can figure out what sort of themes are publishable or are fundable. You can match that against what's been published in the literature, so you can see sort of what trends are occurring in the literature and what's being funded, and you can um, uh, get the AI to write the grant and hone in the ideas, um, using all of that information available. And you can do it agentically in the sense that it's a few prompts. You don't, you give it the idea of what you want it to do. You wait for it to process. You come back. It might ask you a few questions, and then you can guide it to produce a draft. So that's if you're just copy pasting things to ChatGPT and ask, write a grant or revise this paragraph, you're 2 steps behind, or 1 or 2 years behind how people are using AI agentically to write grants.
Lots of questions. I don't. I've got lots of questions written down, but they're coming. They're coming thick and fast. Harry, I'm going to come to you.
Okay, so maybe it comes to a question about AI honesty because I'm using it increasingly in all sorts of workflows, which because it saves a ton of time. Um, when you're reviewing an article, you're not allowed to put it in, upload it to AI. In fact, you have to sign something saying that you haven't done that. I'm not sure what the real risk is or what anything that happens to that data or whether that would be bad or not. But what are the what are the risks of using AI for integrity or for being criticized by your academic colleagues? Are you allowed to write your NHMRC application with AI?
I think there are policies now around that. But let me spin it back: is how enforceable is it? But also, if everyone else is doing it and you're not doing it, you're also at a disadvantage. But I think, I mean,
Everybody else
look,
jumped
I
off the
looked
bridge
at
as well.
the EMCR MRFF scheme recently. It's a 3% success rate, and I have to think to myself, why am I going to put 3 months of time in um, at a 3% success rate? I'm actually got a better success rate if I put in 50 small grants and write them all with AI than put in one massive application. Like my average funding success rate, um, what's it called? My average returns is going to be higher if I target a lot of small grants with AI than if I wrote cleanly and a full 3-month MRFF grant. But I think going back to taking a step back, I think I use AI to um, I try to still do the underlying thinking, but it helps convert ideas into text. When I use it in radiology practice, for instance, like when I'm reporting a complex scan, what I'm starting to do now is I'll just splurt out all my findings, um, uh, and it won't make grammatical sense. There'll be lots of typos. I'll put question marks when I'm uncertain, but I can pass that through to the AI and ask it to synthesize a report, and then I verify that I agree with the report, and that saves me time. But I'm still reading through what it's generating and agreeing with it before I send it off, because at the end of the day, it's my name on the report, not Claude.
So that comes back to the liability. So over here, over here. So if Lou, if I make a mistake, if I copy something into the email that's wrong, is it the AI that listened wrong, or is it my fault?
Yeah, unfortunately, Craig, we have to take the ultimate responsibility, like in most things that we do, whether we're reading a paper and interpreting it, or whether we're using Charm to order the chemotherapy, and whether we're using AI as a dictation or scribe, or whether we're using open evidence or whatever. I mean, we have to be. We unfortunately the buck stops with us, right? It's ultimately unless there was some sort of, I guess, fault with whatever we're using. But I think it's we have to use our clinical discretion. We're using these tools to help us in practice, but we must use all of the tools that we've got throughout our training to make those appropriate decisions. So I kind of feel that the buck does stop with us.
But let's take that one step further. So, Natanj, say I am a recalcitrant old oncologist like Tony Dowling, um, who refuses to use the open evidence that's part of the highly. He'll begrudgingly use the AI scribe, but he won't turn on the open evidence, and then doesn't take into account a drug interaction or something else. Is there going to be a liability issue that you didn't use the best tools available, or how will that work out in practice?
Well, absolutely. It's no different than not using the best possible evidence in front of you. So, if you're not using the best possible tool that is out there, then perhaps you are also doing disservice to the patients themselves and to yourself as well. So, you should be using the best possible tool, which obviously changes in a rapidly changing field. And obviously, that becomes your responsibility to stay on top of that.
So, hello. I'd like to take this to, I guess, a broader societal perspective. And I think what we've been talking about are immediate short term gains. How do you game the system? How do you do things faster, better, quicker? Use the systems that we have. But actually, that comes at a cost. And I do think we're kind of at a point of, I'm really concerned about critical thinking and critical decision making in society more broadly, not just in oncology or just in medicine. And how do we teach people to critically think about these things when the answers appear to be so simple and straightforward? And working in a university where we're talking a lot about AI and our need to teach people how to use it, which I completely get, and I'm on board with that. But I think coupled with the appearance that actually, in a broader sense, our societies are way less critical than they have been in the past at sometimes. Maybe I'm kind of making that up because I come from a different perspective. But also, as probably one of the sole psychological people in the room, there's been a lot of talk about replacing psychology with AI and AI chatbots, and there's been some pretty disastrous, models that have actually generated some harmful outcomes. So I'm not quite as on board with let's jump in with and I don't think any of you have sort of talked about this in terms of clinical care, but plenty of other people are saying, AI models and AI chatbots can replace real human interaction. And so I think there are two things that I worry about. One is, well, actually three. One is who's gaining from this? So who owns these systems and who's benefiting financially? How are we teaching people to be critical thinkers? And how are we maintaining the human connection?
Question.
Mm.
Yeah, well, I mean, I guess
Answers on the back of a postcard.
I can take up the clinical connection thing. I mean, this is more from the AI scribe, and I think that it's quite clear that I certainly see in my practice using an AI scribe, I am sitting there looking at the patient. I'm not worried. I'm not typing. I used to be there watching my screen. I didn't see the cues from the patient when they were getting distressed or feeling concerned or what he needed the tissue, and I wasn't there to hand it to them. So I think that it's the way that we use the tools. I'm hearing what you're saying, but I think that there can be huge benefits for the patient perspective as well.
I think in terms of reasoning, it is probably um, popping the balloon of sort of professional vanity, thinking that clinical reasoning is something only clinicians and other people can do within their respective fields, right? Because all it is pattern memory and looking at guidelines. So perhaps if machines
Is that a
are, if machines can do something better than us, then that gives us more time to think about how we can add value to the patient and to our lives themselves. That's probably like the philosophical response to the question.
I might just chip in a slightly different perspective as well. I'm going to put a private radiology practice hat on, and um, I think a lot of the implementation and integration is going to be driven by the economics. So, for example, if I'm a private radiology clinic practice or owner, and I need to decide whether or not I use an AI tool, then what's going to drive my decision is not clinical performance. And I say that because being more accurate, like everyone has, preferred radiology providers, right? But do your patients know which practice is the better practice, is more accurate, gives better reports? Probably not, right? They're going to go to the clinic that's closer to them, that bulk bills them. Um, and, you know, the for the private practice, the throughput of scans is what determines whether or not you're going to use the tool. Is that going to increase your throughput? And on the liability aspect and things like that, if AI makes errors from a private practice point of view, that error only feeds back if the patient sues the clinic. There's no financial penalty on the patient on the clinic unless the clinic gets sued. So I think the economics, the real world economics, are going to determine really the uptake and how the AI is going to be used. And that's a private radiology practice point of view, but I think it applies actually quite broadly.
Yeah, I mean, very provocative, talks, and if and I have a personal interest in AI, and our department does a lot of AI research. The what I always find is that we get all these papers at how good AI is, but there's ridiculously low clinically implemented, properly tested AI tools. Ridiculously low. So there's a lot of promise. It's like this chess prodigy who's 8 years old, but never materializes into a grandmaster. So I think that we underestimate what the roles of clinicians and doctors in general are, or healthcare practitioners are. I think it's very easy to talk about a simulated environment where curated data is fed into AI and it does a lot better than doctors. But when it comes to a very fragmented, unstructured, multilingual scenario, AI is not as good as we we think that AI is. And I'm not just talking about AI researchers. I'm talking about clinicians, and in our clinical practice, it's very difficult to monitor some really stupid things that AI does. So I think that between the promise and the actual clinical implementation, the gap is really big. And I take the point that he put up in his last slide, that a lot of promise was made in 2015, 2016, and that promise hasn't materialized. And I think that there is a little bit of humility that needs to come into AI research. Much as the promise that there is, it's going to be a very long way off before very critical tasks, because doctors have to do things. They have to come in the middle of the night to sort out problem. They have to do things which an AI simply cannot do. It's just a brain sitting somewhere that doesn't have any hands, doesn't have any action that it can actually perform. It cannot comfort a patient. It cannot come in and check whether the IV line is okay or not, or whether there's an infection in the PIC line or something like that. It cannot do that. So I think that there's a big gap between the promise and actual implementation.
So I agree there's a gap, and I did talk about that also in my talk. But I might just mention, well, compare that with pharmaceutical drug development. So it takes 12 to 14 years from discovery to phase 4 for clinical practice. Deep learning was basically not around 14 years ago. It's coming. It's coming very quickly. We can talk about the gaps. We can criticize issues with it, but it's coming. The big tech companies are going to solve a lot of those problems. It's going to put out a lot of AI researchers out of jobs. When ChatGPT came along, like a couple of years ago, that destroyed natural language processing research. It destroyed it overnight because ChatGPT basically solved, all of the interesting problems in NLP, and the subsequent work was just working around the fringes. And the big tech companies have the resources, compute power, to handle all of these tasks. The data problem is going to be solved eventually. They're going to gobble up all the data that's available, and yeah, it's coming.
I would just like to add that, the prodigy example. Now, obviously, every grandmaster out there was a prodigy once, right? And therefore, you looked at the generative model publication from OpenAI in 2016. Back then, people also ridiculed it as something that is impossible. But 10 years later on, it's here, right? And we don't really know what will happen in the next 10 years, given the rate at which these AI systems are doing tasks. As I showed in my presentation, they've gone from seconds to minutes to hours, and soon they'll go to days as well. Then they can do so many more things. And the other point about, who's going to check up on patients, perhaps that's a question that we should be asking ourselves. Like, is that something that should be done by a clinician as well? If the decision is already being driven by the AI systems, right? Do you need to be there to do that? Or does anyone need to be there to do that? But that's something we can discuss more and more as the systems proliferate and are implemented within our healthcare system.
Explosive stuff. Brandon, one question.
One.
Okay.
One.
Okay, there's multiple parts to the one.
One.
No,
One. He's been running notes.
I I have a lot to say.
No.
So
One question.
I want to think about the implications for privacy. So we talk about that there is great security, blah blah blah. No, there isn't. My medical center, my GP was actually breached, and they had all of their data taken. They were using generative AI, and they were actually held at ransom. We still don't have my medical notes at the new practice, and the practice that I had actually went, well, we don't actually know what's happened because there's legal stuff going on. There's not a lot that the government can do. And when you look at our privacy laws, they haven't really updated to what we're doing with AI. So I guess not really a second question, but I'll try and loop it in. If I was your patient and said that I don't actually consent to have you use generative AI, would you still treat me? What if, like, there's a whole bunch of people in my generation of Gen Z that we actually don't want AI used? So would you just not see us and we'll see someone else? Because that would mean that you do have to do that extra work, which I'm sorry, but
I- I've still got my dictaphone. I tried to give it away to the admin staff, and they said, "What is that?" Of course, I mean, I think as I mentioned before, consent's incredibly important, and I think that over time, I think I've had one patient. It wasn't even the patient; it was the patient's wife who didn't want us to use AI, and we didn't use AI. So I had to go back the old-fashioned way. I mean, the other thing is when Heidi goes down, I'm sitting there thinking, "Oh my God, what do I do?" And that is another consideration when we actually become so reliant on these resources. But no, I think we have a duty of care to the patient, and that's certainly my opinion that I would still offer the patient treatment and just not use the scribe.
I can speak from experience. A couple of patients who refused consent for the AI, and so their clinical notes were feeling okay, no new problems, PSA stable, review in 3 months, script like they always used to be, like they always used to be.
Yeah, and I have noticed over the last couple of years. I mean, I think that people were, um, taping me, recording me more than I was recording them, and sometimes even without my consent, actually.
Any further, the privacy breach is awful. But what is the pathway forwards for those kinds of considerations? Um,
Well, the systems have to get better, and that sits with the government, and that brings out the whole regulatory thing, right? So TGA, FDA have to take the lead, and so do professional societies as well.
is it the develop? Is it
Well,
the developer or the regulator?
So OpenAI didn't make this, didn't put out generative models to be used in health. We are the ones who have turned those models to use them into health. They have their own data provenance, they have their own data security measures themselves. But when we turn that into a different purpose, so the problem therefore lies with the group of people that have turned that into using it for health reasons.
Oh, no, I don't have a question.
No, good. Go.
I'm all on board for the AI, and I think that's great in certain circumstances, particularly like the Heidi scribe and those sort of contexts. But I think that the first speaker showed the graph where you could plot anything that trends up, trends down, and then sort of plateaus off over time. So where are we in that curve? And my I guess my question as to where we are on that curve is the checks and balances, particularly if you're using it in a context of patient treatment management. Where are the checks and balances for that? Because we know that most AI tools are pulling information from all these sources. Some sources are better than others. Some are not that reliable. Even peer reviewed journals. Um, so how? And I guess it comes to what Jenny just said. I think that's up to the developers to get a lot of better at, is to test and validate their particular software or tool before they then go and try and promote it to government, industry, clinicians, etc.
So for example, this knife, the manufacturer of this knife is liable for the way that I use the knife.
Um, two things. With regard to the knowing your model, I mean, no one knows the model. It's been trained. It wasn't programmed. So the developers have no idea what the model's going to do. So they can't. I mean, it's been trained with data. They can then test it, but the model, no one knows exactly how it's going to behave. And so my second question was, you were showing Moore's law, the computer's getting more and more powerful. Do you think we'll move towards having, for simple stuff like Heidi, I mean, it's not that hard, right? Do you think that'll just go onto a local server rather than us sending it off to try and stop some of these problems? So keep it local, keep it on a local machine, rather than sending it all off where it can be breached.
Yes, definitely. Like the tech's there, and you can you can run agents on your own local models on your own systems, and that's done widely outside of medicine. So the tech's there. It's just a matter of uptake. We've got just an example. We've got a clinical AI system we use in SA Health for chest X-ray or flagging abnormalities on chest X-rays, and that product, for instance, has an option to run locally. But that means you need to have your own compute servers, or you can run it on cloud. So it's up to the buyer, which the buyer has the option.
I think that's the same with Heidi as well. They have a Heidi Vault system, and if you've got particularly, I guess, with the bigger public institutions, they're wanting to kind of maintain their own data. So I think that those things are going to happen.
So, surprise, surprise, I'm going to be ornery and say, we've been talking here about privacy breaches in AI, but privacy breaches didn't start with AI. It started with electronic medical records, most of which sit outside of our institutions. And it's not the AI that is our biggest risk. I sit on a hospital executive. I get to have the glory of roundtable discussions on cybersecurity and how do you negotiate a ransom. I'm lucky never to have had to do it. But I guess there seems to me to be a lot of fear around AI without understanding that for 25 years, privacy breaches have been happening and it's got nothing to do with AI. It's because we're an electronically driven healthcare system. So that's my comment for the rest of you.
So can I pick up one thread from Dave? So say we've got an agent on our laptop, and we're using it to assist us in the care of the participant or care of the patient. What's the implication there for embedding research into everyday clinical consultations? Is that something that we can then use the agent to start to help us with the data collection, data cleaning, the data coding? And if the AI is embedded on our devices, can we then federate the data and the learning from those processes as well?
Yes.
I know, I set you up for that one. So maybe ANZUP's next investment should be an agentic AI model that can be downloaded and implemented on the laptops in our clinics with high levels of security, able to interrogate what's happening with our patients who are consenting if they're well aware of what's going on, and that they're collecting the results but not the PHI, not the data. And then that will transform how we do clinical trials. We'll call it Dave. I'm sorry, Dave, I can't do that.
Yeah, look, I think the tech is definitely there, and a few months ago I was having a chat with Claude. about using an agentic system for like MDT decision making, like pulling in medical records and doing literature rags, LLM rag searches, uh, building in like a patient portal where patients can put in like prompts, for monitoring symptoms and follow up and things like that. And I thought it was a great idea. And then I did a literature search and I found that people have really been publishing this for like the last 1 or 2 years. So the tech is definitely there. Um, it's the deployment and integration that's where I think the challenge is going to be. Um, but I don't see any limitation in terms of what is possible from a technological point of view.
I think that's really fantastic. And I guess my additional comment, wearing my ethics hat and as a researcher, what I am seeing is very incredibly variable perspectives on what is acceptable in terms of open data. And having had an ethics, so I sit on a university ethics committee where I think we're kind of reasonably liberal about some of these things in terms of what you might use data in the future for and what people are consenting to. But having had a recent experience of putting a student project through a hospital ethics committee and being told that keeping your data in perpetuity, even though it was completely anonymized, and making that potentially available for future research was not acceptable. It was kind of an interesting challenge. So I think that the systems and the AI and the data is there, but I don't think our ethics and our governance processes have kind of caught up with that. And I think that's a discussion that a group like ANZOP needs to be leading. Comments?
Is that the kind of issue that COSA is leading?
Yeah, so we'll be looking at the ethics governance issue as well and how systems definitely need to be updated to keep up with the speed of AI. Absolutely.
What matters most? Is it patience? Oh, here we are. Belinda.
I just really felt the need to say something because we've been really listening from the clinical point of view and how you use AI. And we've got a reasonably educated group of consumers in the room. Thank you to the wonderful CAP. And I do chair the CAP. And AI is a pretty scary thing for all of us. It, and I still think we're just building such another, it's needed, but there's still a really big divide between patients who get to get like we've still got that like the regional rural gap that's becoming. I just see AI like widens that gap because of access to sort of all of that. I'm very privileged. I'm treated at a very prestigious place. I see my clinician by the time I get home. My notes and everything are all written. I have graphs for whatever is happening, said to me. But I still find it really, really scary listening to, sort of where we're going. It seems like it's a really big fishbowl of unknown. And our patient data being protected is really, really important. But I also think it has some amazing sort of things long term when we like put in like all of the clinical data and we do all the more the genetic testing and you can just ask it a question and it will provide information about the way that we get best treated. But I just really want to say something on behalf of it's really hard. It's scary, but it's great. Um, but yet the patients are what matters most.
If I could reflect on that, the people who found consenting to AI transcription difficult for me were presented with a consent process that I felt was not very well thought out. They were presented with a consent process of here's a very, very densely written sheet of paper with a lot of words on it, sign here. So that wasn't my decision to use that, but the responsibility to take from that is that we need to inform people really well so that they understand like we do with our clinical trials, to make ourselves well understood and check that people understand us. Do all of our patients understand us, Lou?
I mean, I was just reflecting on, the consent and the process and, look at the patient-informed consent documents we have for clinical trials. How many of our patients actually read all of those? I think they find them very overwhelming. And in fact, if anything, they kind of put them off going onto a clinical trial. It's really up to us to help them digest that information. The same as that huge, big consent bit of paper, which we probably have to have medico-legally, but we have to actually sit with the patient and go through that and have that dialogue. It's a very important piece. What was the actual question?
No, that was the question. That was the question. But then the other point that was raised is, is the buzz, is this AI, this incredible innovation, like all other technologies, is it going to become unevenly distributed as the rich get richer and the regional centres and rural and remote patients continue to get poorer and poorer service? Does AI have any, has it made any claim that it's going to bring better healthcare to places in remote parts of the world who are less well served at the moment?
I think I was hoping, if anything, it would do the opposite. I mean, we all already know that things like telehealth have significantly reduced disparities within Australia for clinical care and clinical trials. So I would hope that some of the things that AI can deliver might actually help reduce those inequities and disparities that we see from socioeconomic to geographical disparities by things like remote monitoring, for example, might be important. Some of that kind of communication that I was showing you with the clinic, I mean, whether it's with a chatbot or not, I mean, just having that ongoing communication. Sometimes people just need to check in and being able to have that done, perhaps, even remotely from a central or a larger center. Having better support, I guess, from GPs, even just sometimes our communicate, even, the simplest form using an AI scribe, you'll find that, your documentation is so much better. It goes back to the GP in a timely way. They can actually look after the patient rather than a discharge summary of one of 388 that hasn't been done, that they don't have that information. So I think there are many ways that, in fact, I would hope that these technologies will reduce disparity over time.
They're already reducing disparities in Canada, so plenty of work is being done over there. And Canada is obviously geographically fairly similar to Australia with densely populated cities and sparsely populated regions. And over there, a group of people have already found that use of AI, and they obviously use Starlink to ensure that, people can use AI in remote regions, and it is helping clinicians go further. So evidence is emerging from Canada, and we hope similar evidence eventually comes about from Australia as well.
Hi. I just wanted to ask about with Heidi. So when you're asking your patients, do you actually get them to sign a written consent that they agree to Heidi
Yeah, we do actually. And then we have
for every? So no.
for
Okay.
every patient, we have to re-consent them. And every single consultation, I mean, they get very sick of me. And like hand on heart, sometimes I forget if it's like a recurring patient I'm seeing every like 2 weeks or something. But, we're always reminding them. We've got signs up everywhere so that they are aware. And it's, as I said, over the last couple of years, because their GPs are all using it, all their other specialists are using it. It's kind of like almost unusual if you're not using it. So,
Yeah.
yeah.
Yeah. So I work in regional Victoria and I use it, but I don't get written consent. I get verbal consent from them. And I have had, and like they're regional, so, and not saying that they're anything like they've not, their ability to understand is fine. But once you explain it to them, I mean, and like you said, it's the hours it saves, like, 3 days of writing for a 2-day clinic. It's just amazing. And it gets back to the GP. So, yeah.
Absolutely.
I have the opposite problem now where I can't consent to closing the consultation because the patient says, "Oh, can I have the output now? Can I have you finish the letter now and you give me a copy before I leave?" Okay, yeah, no problem. But that's the expectation.
Still have to, sorry. So with using AI, like when you're starting off, you still have to read your letters because it's AI, and they always, like, I'm a nurse practitioner. They always call me doctor. I'm just like,
Yeah, I mean, I think absolutely we have to. What think is that once you've used a tool for a long time, like anything, it becomes much more personalized. It still makes mistakes on patients' names, and I have to say that the area that I live in is not very culturally and or diverse. And so I'm not seeing a lot of patients that English isn't their first language, and so I don't know how other people are finding that in kind of more culturally diverse environments, but it absolutely. I think if you've got a really good template and you keep improving your template, I'm finding that I'm needing to do far less corrections. But of course, you need to always, sometimes it just comes out with some bizarre stuff. Like when I first started using Heidi, this is like, and I had very poor templates and I was just practicing. Every single patient that day was on pembrolizumab. I did check it and fix it.
Thanks for a great presentation. I'm just wondering what the next move is in terms of incorporating all that indirect stuff we learn from patients, the body language, their emotional complexities. I mean, for example, this week, my moustache colleagues will know that I've got sent a patient who was 52 and fit, and who had query neoadjuvant chemo. And I learnt so much by her being in the room, that had been missed out in the referral letter, no next of kin, previous schizophrenia, had lived in a car, all sorts of crazy things so how are we going to train the AI to ask the right questions, to synthesize so much more information than just the basic data of that patient, to make the right decision for that patient?
Well, I think if you're talking about using the AI scribe, I mean that's going to come from everything that you talk about in the clinic. And when I'm using an AI scribe, when I'm examining the patients, I explain to them I'm going to talk as I go, and they actually quite like it. We say what your blood pressure is, where you've got no lymph nodes, the breast examination. We talk, and they actually learn a lot from that, which has surprised me. So that all kind and I guess it other things they can pick. It's fascinating, but it can kind of pick up on tones of voice and things that the family members are perhaps saying to the patient in the clinic. It's really quite fascinating to see what. Yeah, like it's.
Yeah, like with the AI, the tech from the tech side of things, it's all possible, right? Like facial tracking, emotion recognition, and things like that. It's a matter of data, having enough data to train the models. The models are easy to train now, and then it's the integration side, but the tech is solved. It's just a matter of someone, and there's probably, if you Google it, there's probably someone already working on this, incorporating emotion recognition in consultations with a scribe tool. And then, it's going to come down to, does the patient consent to having a scribe as well as a camera?
So we actually did something similar using Vision Scribe. So we use Ray-Ban Meta glasses that can obviously record. And we did consult, like in pharmacy, with patients, and we found that Vision Scribes reduce error rates by like 99.9%, because then you can incorporate the body language using the Meta glasses. So we wrapped it in Gemini and then we did a model. It worked really well.
So, if the scribe's picking up those cues, are they going to pick up when we're tired or bored or rude to the patients? Is that going to be
It did.
That's going to be
Yeah.
recorded?
So it did pick up, because I was role playing as a pharmacist, and it picked up that I was a bit abrasive with this patient and I could have been better. I mean, all that feedback is useful. So that just tells me that I need to be better.
All right. Well, that's been an extraordinary long panel. I didn't know how that was going to go, but that went very, very well. We've talked about an enormous number of things here. I think we could go a lot longer. They are going to kick us out in 15 minutes, so I think we'll wrap it up there. Join me once again in thanking the panel. That's amazing. Thank you so much. Wonderful presentations. Thank you. Thank you again to all the sponsors who keep all these events happening for Hands Up. It's incredible.